Welcome everyone. Welcome to Mike Fave Science. Today I'm going to dive into GLP-1 agonists and go through the literature and talk about their mechanisms of actions, why they may not be the best idea, what we can use instead, and what are some of the problems that we see with these drugs. So what I want to start out with here is I want to talk about what is GLP-1 anyway? What is glucagon-like peptide 1 anyway? And why are we making these drugs from it? What's so important about it? What are its effects? So to start, GLP-1 is released from the L cells in the intestine from the intake of fats, sugars, and proteins. So when these cells in the intestines get the sense that there is fat, sugar, and protein coming into the gut, what they start to do is release GLP-1, this hormone, this peptide hormone. Now, what is GLP-1's job to do? GLP-1's job is to essentially tell our body, hey, we have food coming in. We have a meal. We have nutrients coming in. And so one of the major things it does is it slows down the rate at which food leaves the stomach and enters the small intestine. And the reason it does this is to allow the small intestine to not become overwhelmed by all the food that's coming in and to essentially be able to absorb all of these nutrients. So it's there as to basically allow you to optimize your digestion. Now, when you have more food come in, you'll release more GLP-1 because the protein, carbs, and fats will stimulate the intestinal L cells. And then the GLP-1 will slow how fast the stomach is releasing these foods in. The stomach basically drips the food into the small intestine. However, when you have less of these foods, you have less of these nutrients coming in, then you can get less release of the GLP-1, and that will help to increase gastric emptying inside the meal. So it's a delicate feedback mechanism to control how fast the food is leaving the stomach and being absorbed in the small intestine. Now, the next thing that GLP-1 does is it lowers glucagon production at the pancreas. And why does it do this? If you're going to have food come in, you don't need glucagon to keep producing or signaling the production of glucose at the liver so that your liver is maintaining your blood glucose levels. So when you have food come in, this is one of the signals that says, hey, pancreas, chill out with the glucagon production so the liver doesn't have to keep producing this glucose because we don't need it anymore. We're taking in the glucose from our food. The next thing it does is GLP-1 signals to the pancreas to release insulin. So this is one of the ways in which the body is regulated in terms of producing insulin in the response to food. So basically, when food comes in, GLP-1 is released, and the pancreas starts to release insulin in preparation for the nutrients that are coming in, the carbohydrates, the protein, not necessarily the fats, but the food in general. The next thing is GLP-1 acts directly at the brain to regulate food intake by affecting the brain feeding centers, and there's a couple of them, and I'll talk about that in a research quote in just a second. And so basically, as you eat more, you'll get more satiety, and part of that satiety is through its GLP-1, GIP, which is another one, and then there's also leptin and other hormones involved that tell your body, okay, hey, we got enough food, we're good to go, we don't need to actually eat anymore. So GLP-1 is involved in this feedback system from the intestine to the hormonal system, letting the body know, hey, we have enough food on board, we're good to go. Now, you can already see how this is problematic to just override this system with these drugs, and the mechanism by which these drugs are working for weight loss is basically just nuking your appetite. So when you're taking these GLP-1 agonist drugs, an agonist is a drug that basically activates the receptor and activates these functions. What winds up happening is you're going to really slow down your rate of gastric emptying. You're going to lower your desire to eat from the brain level. You're going to lower glucagon production, and you're going to increase the insulin production overall. So basically, you're just going to nuke your appetite. You're going to create all these satiety signals, even if you have way less food. And so you basically are inducing caloric restriction, and depending on how low you go, starvation, by making yourself not hungry with this drug, which I think there's some problems with this. Overall, and we're going to dive into those, and that's why I'm actually making this video. Now, what is the mechanism of actions of these drugs? So the documented mechanism of actions from the research, the first one is there's appetite suppression at the brain. So I'm going to share a quote here so that you can see what I'm talking about. So what they say here is experiments in mice have shown that intraventricular administration of GLP-1, GLP-2, and OXM could significantly reduce food intake. So the intraventricular is into the ventricles of the brain. There's a cavity in the brain called the ventricles. They're fluid-filled. You can inject these hormones into there. Central GLP-1 activation may be combined with GLP-2 and or OXM. These are two other hormones. Activation to form a potential pharmacological tool to reduce meal intake and possibly increase energy consumption. The expression of GLP-1 and or GLP-1 receptor was found in hypothalamic feeding centers, so the areas of the brain involved with feeding, the hindbrain matrix, the lateral parabrachial nucleus of the posterior nucleus, and mesolimbic substrates, etc. Parts which directly affect appetite and lead to weight loss. So basically, when you are taking a GLP-1 agonist, if the GLP-1 agonist is getting into the central nervous system, then what winds up happening is actually suppressing food intake by interacting with these various centers. So it's directly making you not hungry. It's basically making you not hungry. The next thing is GLP-1 agonists can directly slow digestion. So they say GLP-1 can inhibit postprandial gastric emptying and reduce gastric acid secretion. So basically, it lowers the rate at which food leaves your stomach, so you'll feel really full, and then it lowers the gastric acid secretion, so you also possibly won't digest your food as well. This is also why a lot of people on these drugs get pretty significant nausea. Now, the other thing they say here is it inhibits gastric and duodenal peristalsis by inhibiting vagus nerve and increases the pressure on the pylorus. The pylorus is the pyloric sphincter of the esophagus that separates the stomach and the esophagus, and these mechanisms reduce appetite. This causes a reduction in body weight and participates in the so-called ileal brake. So the ileal brake is essentially a phenomenon in the intestine where when you have a bunch of fibers or different components coming in, the food isn't being absorbed appropriately. The small intestine will slow how fast the food is moving through the intestine so that you're more able to absorb the nutrients inside the intestine. So basically, GLP-1 is inhibiting your ability to digest your food to some extent and basically making you full for a really long time in the digestive tract while lowering your desire to eat in the hypothalamus. And this is, I think, why a lot of people, the major side effects of these drugs are really gnarly digestive side effects. That's bloating, that's gas, that's diarrhea, possibly constipation, and then really bad nausea, and for some people, vomiting. And what we'll see later is that some of the weight loss in this study, some of the people who get the best weight loss are the people who vomit the most. So it's a great mechanism for weight loss is vomiting. That's obviously sarcasm for anybody out there saying, oh, Mike's promoting eating disorders. I'm not, I promise. I'm actually talking about problems with these things. The next thing is GLP-1, and this is actually kind of good. It suppresses glucagon. Now, under normal circumstance, when you eat food, your glucagon will be suppressed anyway. It's when you're diabetic that glucagon suppression is not occurring, and that's problematic, and that's why these drugs were initially marketed and produced for diabetics. But the research quote here says that GLP-1 inhibits the production of glucagon from pancreatic alpha cells if blood sugar levels are high. So this is another benefit of this drug for diabetics, is that it doesn't actually produce hypoglycemia because it will lower glucagon secretion under the face of elevated blood glucose levels, but it won't necessarily lower blood glucose levels below baseline. So there's a benefit there, and that's why it's also touted for diabetics, but I don't think that this is necessarily ideal for people, normal, healthy people overall. Now, the next one is actually partly beneficial in a diabetic circumstance, but in healthy individuals, I think it becomes more problematic. So this is the GLP-1 agonists stimulate the beta cells of the pancreas, which are the cells of the pancreas that produce insulin. And what they say here is, furthermore, GLP-1 receptor agonists can decrease pancreatic beta cell apoptosis while promoting their proliferation or their growth or their increased numbers of these cells. Now, in diabetics, this could possibly be considered a good thing because the pancreas is under a lot of stress. A lot of the cells, the pancreatic beta cell mass, or the amount of these cells, decrease over time. So this drug is protective in that circumstance. But in normal individuals and in some of the post-marketing surveillance of these drugs, when they put them out in the market and they got to see what happened when real people started taking these over the long term, or larger numbers of people started taking these, what they found was that people were getting pancreatitis. And the pancreatitis is likely a function through this mechanism where you're decreasing the apoptosis of the pancreatic beta cells, and you're also promoting the proliferation of these cells overall. So it's also like a dual-edged sword. Maybe it's beneficial inside diabetics, but it seems like there is some possibility where it can create problems inside normal individuals. And these drugs are actually contraindicated in people who have history of pancreatitis because of this effect. And then as far as pancreatic cancer and thyroid cancer, those were other contraindications or possible worries about using these drugs, but the information isn't 100% clear on this yet. So these are the mechanisms of the actions of these drugs, and we have the context of GLP-1. Now the question is, how good is the weight loss from these drugs? Like, are these drugs really getting us to lose a lot of weight, or are they, doing a marginal job? I'll give you the TLDR. They're not doing that great of a job, especially compared to modalities that we already have present in terms of if you're going to lower your caloric intake and you're going to exercise and things like this. Those actually, I think, would be, if not equivalent, superior for many other reasons that I'm going to talk about in this specific video. Now, there's a variety of different GLP-1 agonists. And I'm going to list off the names here. There's exenatide, there's lixisenatide, there's liraglutide, there's semaglutide, and then there's dulaglutide. These are the major or main drugs on the market currently that people are using. And so let's walk through and see how much weight people are using with these drugs. Something to keep in mind is the timelines for a lot of these studies are in like a year or more, or 6 months or more. Most of them are around a year or more with the utilization of these drugs. Some of them up to 2 years, some of them up to 18 months, so between the 1 and 2 year mark. So for exenatide, the quote here is, at present, the studies of exenatide on non-diabetic obesity mainly include 152 cases of simple obesity, where they saw a weight loss of 5.1 kilos, so roughly, I think that's 11 or 12 pounds, somewhere around there. Then you have 60 cases of polycystic ovarian syndrome with a weight loss between 3.2 to 6 kilos. So that's between 7 pounds and maybe like 13, 14 pounds. And 10 cases of metabolic syndrome, weight loss of 3.7 kilos, so that's maybe 8 to 9 pounds, among which the most common adverse reaction is still vomiting, which I mentioned before. So a lot of people are getting nausea and vomiting on this drug because it impairs your ability to digest food. And basically what we're seeing is the weight loss is roughly 10 pounds, maybe a little bit less, maybe a little bit more, and this is over a long period of time. So this isn't really that great. This is not amazing weight loss. If this is extrapolated over a year's time frame, then we're not even seeing a pound per week of weight loss, which that would be the standard to shoot for when you're looking at diet and exercise interventions. Plus, we'll talk about rebound weight gain when people come off these drugs, and we'll talk about the negative side effect profile and loss of lean mass. So stay tuned for just a few minutes for that. Now, the next one, lixisenatide. We have a quote here. They say in the I-GLAR-Lixi, so that was insulin glargine, which is long-acting insulin, plus lixisenatide in a 1-to-1 ratio. So in this study, adult Japanese patients with type 2 diabetes lost more weight compared to when they just took insulin glargine alone. So in the lixisenatide group, plus insulin glargine, they lost half a kilo. And in the insulin glargine group alone, they gained half a kilo. Now, there's another study here. They say in the GET-GOAL-S, a sub-analysis of GET-GOAL-S and GET-GOAL-F1 studies, they found that lixisenatide could significantly reduce subjects' body weight. So, negative 1.6 kilos. This would be in GET-GOAL-S, and then negative 1.12 kilos in the GET-GOAL-F1, respectively. So essentially, you're not really seeing that much weight loss with this, at least with lixisenatide here. In these studies, you're seeing 4 to 5 pounds, roughly, which not even maybe 4 to 5 pounds. Some of them are like 3 to 4 pounds. So not really that great overall in terms of weight loss. Not a massive difference. If somebody's holding a lot of weight, it's not going to, 3 to 4 pounds is kind of neither here nor there. Now, the next one is liraglutide, and this one's actually kind of funny because this is where they talk about the vomiting. Now, with liraglutide, the quote here says, a clinical study involving 564 adults with a BMI between 30 and 40 kilograms per meter squared without type 2 diabetes found that compared with orlistat, so the orlistat was dosed 3 by 120 milligrams, and they saw a weight loss of 4.1 kilograms with the orlistat. Liraglutide, subcutaneous administration of 1.2, 1.8, and 2.4 milligrams or 3 milligrams per day had an average weight loss of 4.8 to 7.2 kilograms. The 2-year extended experiment of which also showed similar results. So again, over a long period of time, but basically with liraglutide, what we're seeing is between roughly 11 and 15 pounds of weight loss, 4.8 to 7.2 kilograms, over an extended period of time. Now, there's an interesting quote here. They say, the relevant study also found that the 1-year average weight loss of participants for liraglutide at the 3 milligram dose was 9.2 kilogram and reported nausea and vomiting episodes, while that of participants without nausea and vomiting was 6.3 kilograms. Researchers believe that the nausea and vomiting is related to greater weight loss. Who would have thought that if you vomit and all your food up and you're really nauseous so you can't eat, that you lose more weight? This is wonderful. So basically, we're seeing 9.2 kilograms of weight loss in people who had nausea and vomiting. This is at a 1-year mark. So over this time frame, over 52 weeks, we only saw like maybe 20 pounds of weight loss, which means less than half pound per week of weight loss. And that was in people who were nauseous all the time and vomiting. Maybe not all the time, maybe that's an exaggeration, but they had more nausea and vomiting than the other group. And then in the people who didn't have nausea and vomiting, we're seeing like 12 to 13 pounds, 13, 14 pounds, somewhere around there for weight loss. So 6.3 kilograms over a year. So that's not really that great of weight loss if you think about it. If you're saying, okay, in 52 weeks, I lost roughly 13 pounds. So a quarter pound per week? That's really not that great, especially when you start to compare these drugs to diet and exercise intervention, right? And especially if the reason you're losing your weight is because you're nauseous and vomiting all the time. That's kind of a ridiculous mechanism to promote weight loss for. That's actually quite a terrible mechanism to promote weight loss for. Now, the best performing drug of these studies was semaglutide. So we'll talk about this one here. And what they say is more than 1,200 patients with type 2 diabetes complicated with obesity were randomly divided into 1 milligram semaglutide, 2.4 milligrams of semaglutide, or placebo group, and given once a week in step 2 research. So the step 2 was the study. The weight loss ranges of the 2 treatment groups were 6.9 kilos in the 1 milligram semaglutide group and 9.7 kilograms in the 2.4 milligram semaglutide group. Okay, so this was roughly 15 pounds in the 1 milligram semaglutide group, and then looks like 21 pounds in the 2.4 milligram semaglutide group. So this weight loss is a bit better than the other ones, quite a bit more. Now they go on to say here further, in the step 1 trial, Wilding et al. Recruited 1961 non-diabetic adults with a BMI of 30 kilograms per meter squared. So basically they're overweight. And the semaglutide group, it was 2.4 milligrams once a week, was treated for 68 weeks, and the average weight loss was 15.3 kilos. So this is actually, now we're talking, this is pretty good weight loss, 15.3 kilograms. So that's 30-something pounds of weight loss, low 30s. Now, something interesting to talk about with this study is this study included, when they were using semaglutide, they also included 150 minutes of exercise per week plus a 500-calorie deficit per day. So you had to take semaglutide, 2.4 milligrams. Ideally, you exercise 150 minutes per week, and ideally, you had a 500-calorie deficit per day. And they had nutritionists follow up with the research participants every couple weeks to make sure that they were doing these things. Now, we can make an argument that most people probably didn't fully follow through with the deficit plus the exercise piece. But we can also assume that a decent portion of them probably tried to do something, especially if they were involved in the study. And so what we're seeing is that in 68 weeks, when you take this drug, you lose less than half a pound of body weight per week while you're possibly exercising and in a 500 calorie deficit per day, which means that this is, again, not that great weight loss. I mean, these results are really not ideal in the long run. And we'll talk about, again, losses in lean body mass and also poor long-term adherence because you're nauseous and you're vomiting and maybe you have diarrhea and constipation from these drugs. Now, the last drug we'll talk about here is dulaglutide. Now, there's a quote here. They say, compared with liraglutide, once a day, once weekly, subcutaneous injection of dulaglutide similarly lowers body weight by 2.9 kilograms. And then liraglutide was 3.6 kilos after 26 weeks of treatment. So after 6 months of treatment, you can expect 6 to 7 pounds of weight loss, which again, this is not really that great weight loss overall. They say at 26 weeks after treatment, the weight loss was negative 2.29 kilograms for 1.5 milligrams of dulaglutide, negative 1.36 kilograms for 0.75 milligrams of dulaglutide. So you're not really talking good big weight loss. You have to be on this for 6 months, and then maybe you'll lose like 6 to 7 pounds. So again, that's not that much weight loss in a really long period of time. The numbers, when you just look at the study, you say, wow, 15 kilos. But then you're like, at 68 weeks, and I had to be in a deficit, and I had to exercise. And it's like, yeah, this is not that impressive. You don't even have to take the drug. You could just go in the deficit, and you can exercise, and you probably lose more weight if you're consistent with that. So especially if things are situated appropriately. Now, here's the next problem with these drugs. There's a significant proportion of lean body mass loss, so loss of muscle tissue and possibly organ tissue when using these drugs. And so when we're looking at 15 kilos of weight loss, we have to say, okay, how much of that is actually body fat and how much of that is actually our lean body mass, which we do not want to lose because we really just want to lose the body fat. We don't want to touch our lean body mass. The lean body mass is going to keep our metabolic rate high. So we have a quote here. They say, in over half of the studies identified, the proportion of lean body mass reduction using these GLP-1 agonists ranged between 20 and 50% of total weight lost, which is consistent with diet-induced weight loss and bariatric surgery. No clear difference existed between GLP-1 receptor agonists and sodium glucose-like transporter inhibitors. Consequently, the loss of lean body mass and skeletal muscle associated with weight loss induced by GLP-1 receptor agonists and sodium glucose-like transport 2 inhibitors warrants attention. Strategies to preserve skeletal muscle improve greater physical function, for example, through structured exercise, are of great importance. Collectively, the available evidence suggests that the initiation of GLP-1 receptor agonists or sodium glucose-like transporter 2 inhibitors therapy results in weight loss that is primarily derived of fat mass. However, this is accompanied by reduction in lean body mass, which are not insignificant. They are not insignificant and should be considered in parallel to changes in fat mass and overall body weight. Differences between therapies are currently unclear. A substantial proportion of lean body mass loss may be comprised of skeletal muscle, which may be clinically relevant, particularly in the populations of which these therapies are prescribed. So essentially, if you're going to go on your semaglutide, right, we're going to go on semaglutide, and you're going to lose your 15 kilos. So at the most, let's see, so 15 times 2.2, that's 33 pounds. So times 0.2, 33 times 0.2. So 6.6 pounds of that is at the minimum muscle loss, and then 16 pounds of that at the maximum is muscle loss. So if you actually extrapolate this out over a 68-week time frame, and you consider that at least 6 pounds to roughly 15 pounds or 16 pounds of that weight loss is muscle mass, well, now you have anywhere between 27 pounds of weight loss over 68 weeks or 33 or 16, roughly 16 and change pounds of weight loss over the 68 weeks, which is not good. This is not great weight loss. We don't really want to be seeing that much lean muscle mass loss. And essentially, what we want to be seeing is people undergoing resistance training when they're doing their weight loss programs or protocols and having an adequate protein intake so that they are not losing large amounts of lean body mass, which again, if you're going to use these drugs and you have to set the diet up appropriately and you also have to exercise, why even use the drugs? Why not just drop the drugs, set your diet up appropriately, exercise appropriately, make sure protein intake is appropriately, and just put yourself in a reasonable caloric deficit? If that's the way that you want to go about this, then take these drugs, nuke your appetite, and wreck your digestion. And lose lean body mass, because ideally we don't want to be losing lean body mass. And I'm going to come back to this in just a second. Now, another problem with these drugs is long-term adherence and maintenance of these drugs is pretty bad. Essentially, at the 1 to 2 year mark, I think it's like 70% of people drop off from these drugs. And I have some quotes here to support this, so I'm not just, talking randomly. So, quote here, median time to discontinuation of using these drugs was 13 months. The discontinuation rate was 47.7% and 70% at 12 and 24 months respectively, with differences at 24 months for age and dosing frequency. So essentially, at the 1 year mark, almost 50% of people dropped off, and at the 2 year mark, 70% of people dropped off. And now, this is a huge problem, because we'll talk about in just a second, a little foreshadowing here, is that most people are just regaining the weight when they drop off. So this is not a sustainable solution if you have to stay on these drugs forever, and most people can't stay on them because they have terrible digestive symptoms in response to this. Now, another quote here, they say, among patients with weight measures available, 33.4% and 43.5% achieve weight loss greater than 5% of baseline weight at 12 and 24 months respectively. At 12 and 24 months, 64.5% and 59.2% were adherent, and 45.2% and 64.7% discontinued respectively. So this is another study, and what they're showing is that at the 12-month mark, 50% of people drop off, and at the 24-month mark, we're almost at 70 again, 64.7%. So essentially, most people cannot sustain using these drugs. They don't get that great of weight loss overall, and the mechanisms by which they're doing it is just by making you not hungry, so you're going into a caloric deficit. So, and if you wanted to optimize this so you don't wreck your metabolism in the long run and don't lose a bunch of lean mass loss, you need to add protein, you need to add exercise, resistance training ideally. So you're already 75% of the way there in terms of structuring your diet to just lose weight without having to use these drugs that basically nuke your digestion. So let's talk about weight regain and cessation of therapy. So following cessation of therapy, so stopping therapy. So for liraglutide, I have liraglutide and semaglutide here. I couldn't find good data on some of the other ones, so I'm going to use these two specific drugs. And semaglutide was actually one of the better drugs in terms of the weight loss, right? Those were the biggest numbers we saw, the 15 kilos at 68 weeks. So this one was better than pretty much all the other ones, at least based on the research that I looked through. And we're going to see what happens when you stop taking it for a year. So we'll start with liraglutide. In our study, discontinuation of liraglutide alone was associated with a regain of 6.3 kilograms of fat mass after 1 year, corresponding to a regain of more than 70% of the fat mass reduction after termination of liraglutide alone. Okay, so if you stop liraglutide within 1 year, if you don't change anything else in your diet and lifestyle, you'll put 70% of that fat mass back on. Great. So you basically need to take the drug perpetually if you're not going to change anything else in your lifestyle in order to actually maintain the weight loss. So, and again, we see that at the 2 year mark, or at the 1 year mark, 50% of people drop off, and at the 2 year mark, 70% of people drop off. So what's going to happen? All these people are going to hop on these drugs, and then at 2 years, 70% of people are going to drop off because they're tired of having digestive issues and not being hungry, and they develop a bunch of other issues, and then they're going to regain all their weight a year later. That's like, for a long-term goal, this is pretty bad, especially because the weight loss is not that significant, and a portion of that weight loss is lean mass loss, and I think it's doubtful that lean mass is coming back to the same extent that this fat mass is coming back. So you actually will probably wind up in a net worse position at the 2 or 3 year time mark from starting these drugs. So doesn't seem that great to me so far. I know there's a lot of hype, but I'm trying to dispel some of that. Now, let's talk about semaglutide. Semaglutide, quote here, they say, following treatment withdrawal, semaglutide and placebo participants regained 11.6 and 1.9 percentage points of lost weight, respectively, by week 120, resulting in net losses of 5.6 and 0.1%, respectively, from week 0 to week 120. So essentially, they basically say cardiometabolic improvements seen from week 0 to week 68 with semaglutide reverted towards baseline at week 120 for most individuals or most variables. So essentially, people are regaining their weight when they're coming off of semaglutide. They're basically only seeing at after 68 weeks, another 60 or 52 weeks later, so a year later, people are only down that 5% of their body mass. Now say, 5%, that's great. So say you're 200 pounds, right? 0.05. So you're down 10 pounds total at 1 year and regained the rest of that 30 pounds that you took off with your semaglutide. So you put the 20 back on, you're down the 10, but we have to keep in mind that at least 6 of that 30 was lean body mass. So I would wonder how much of that is this weight loss, because they're doing it by percentage of weight, is actually weight loss from lean body mass. So this still isn't that great overall. Again, it's showing it's not really sustainable unless you're on the drugs perpetually. Okay, now what's a better strategy? What does caloric restriction plus resistance training or exercise look like? What are the results that we can expect from that versus just injecting these drugs? Okay, so exercise plus caloric restriction. Now let's talk about how long are the people, and this is very important, is how long are they actually running these studies or these trials? So regarding exercise prescription characteristics, the mean intervention duration was 14.6 plus or minus 11 weeks, with frequency ranging from 1 to 5 sessions per week. Okay, so we're seeing that these exercise interventions were around 14 weeks in length, plus or minus 11 weeks, so between 14 and 26 weeks, so a quarter of a year to a half a year. And then basically what they say here is, for reducing fat mass, both resistance training plus caloric restriction and combined resistance and aerobic exercise plus caloric restriction were the most effective, with a loss of 5.1 kilograms and 5.3 kilograms respectively. So if you undergo resistance training, you're going to go lift weights and then put yourself in a bit of a caloric deficit, maybe 300 calories, 500 calories, 200 calories, whatever the deficit is that's appropriate for your certain context, or you're going to do aerobic exercise and caloric restriction, and with resistance training, you'll lose about 10 to 11 pounds. Now, this is on average, a 14-week time frame, which means if we extrapolate that out to this 68-week time frame, right? So we're going to take 68 divided by 14. So that's 4 cycles of the 68. And then we're going to put in here this 5 kilos, so times 5.1. That means that in a 68-week time frame, you can expect to lose 25 kilograms doing resistance training and caloric restriction, which, in case anybody's interested, times 2.2 is 54 pounds. So if you were to undergo resistance training and caloric restriction and do it appropriately, you will lose in a 68-week time frame, about on average, through an extrapolation, 54 pounds. Assuming the 5.1 kilos from these different components was in a 14-week time frame. If it was a 26-week time frame, because we had the standard deviation of plus or minus 11 weeks, then essentially you would lose 10 kilos in a 52-week time frame. So the 10 kilos, you would be losing about 22 pounds. So still, that's on par with these drugs, if not significantly better than these drugs. But we're not talking about lean body mass yet, and we'll get to that in just a second. Now, another interesting piece that I want to drop into this section here is GLP-1 agonists work better with exercise anyway. So if you're going to use a GLP-1 agonist, you probably should exercise because the results are better and they stick better. So the quote here, they say, the addition of supervised exercise to obesity pharmacotherapy, these are the GLP-1 agonists. This study was coming from information on liraglutide, seems to improve healthy weight maintenance after treatment termination compared with treatment termination of obesity pharmacotherapy alone. Body weight and body composition were maintained 1 year after termination of supervised exercise, in contrast to weight regain after termination of treatment with obesity pharmacotherapy alone. So you hop on GLP-1 agonist, you don't change anything else, and then you hop off because you're vomiting every day and you're constipated or you're having diarrhea. Well, 1 year later, you're just going to regain the weight, or at least there's a very high probability that you will. However, if you undergo exercise while you're doing this, then it's very likely that you'll actually keep the weight off if you actually learn how to exercise in this weight loss process. So basically, I know it's boring, but diet and exercise is the number one way so far that we still have to actually induce effective weight loss. And these drugs are not, if the higher targets and estimates are correct, these drugs aren't even close in comparison. Now, again, we haven't even touched on lean mass. So what I want to talk about is the lean mass component now, and then we'll talk about some problems with some other alternative problems with these drugs. So with lean mass, or with the GLP-1 agonist, we talked about this 20 to 50% lean mass loss. Well, what happens with resistance training? So here's a quote. The main finding of the present meta-analysis was that caloric restriction plus resistance training prevents 93% of the lean body mass loss induced by caloric restriction, although it does not affect body mass and fat body mass reductions as compared to caloric restriction without resistance training. So essentially, if you undergo caloric restriction and you also incorporate resistance training, 93% of the lean body mass that you will lose will not happen. You won't lose 93% of that lean body mass. You'll only lose 7% of the lean body mass of that 20 to 50%, which is a significant drop off. So this is caloric restriction plus resistance training. Now, why is this comparable with these drugs, this caloric restriction versus the caloric restriction alone? Because these drugs are working through caloric restriction. They're nuking your appetite, and then you're not eating, and that's how you're losing the weight. So it's caloric restriction, and whether you're nuking your appetite with a drug or whether you're doing it consciously, it's caloric restriction no matter what. So basically, if you calorically restrict and you exercise, you'll preserve 93% of your lean body mass. So you need to work out if you use these drugs if you want an effective outcome. Plus, with the study that we just talked about with liraglutide, if you actually wanted to maintain your results after using the drug, then you need to be exercising, hands down. So you need to learn how to exercise whether you're on this drug or you're not on this drug and you're just going to do caloric restriction, which is again, this is this is more reason to just do the diet and exercise stuff instead of try to use these drugs to nuke your appetite and mess up your digestion. Now, another problem that people don't talk about is caloric restriction causes loss in bone mass. So so I have a quote here to discuss this. And basically what they say is, and I'm not doing this from the GLP-1 agonists because the GLP-1 agonists are working through caloric restriction, but they haven't been used long-term enough to look at some of the bone mass parameters. But there are studies on caloric restriction where you can actually see effects on bone mass. So the study here is on a caloric restriction trial. And they say in longer-term Calorie-2 trial, bone mass significantly decreased at clinical important sites of osteoporotic fractures, such as the hip and femoral neck and the lumbar spine. So these are the areas where you're most likely to break your bones and then be in the hospital and have to get hip surgery and all this type of stuff. So these are where you're going to get your fractures. And basically, caloric restriction increases your risk for developing these fractures because it decreases bone mass significantly. Now, the next thing they say is changes in body composition, macronutrient intake, physical activity, and plasma hormones, vitamin A, vitamin D, cortisol, IGF-1, adiponectin, and leptin explain 31% of these changes in a multiple regression analysis. These findings clearly represent a potential limitation of the implementation of caloric restriction, perhaps in some older persons where accelerated bone loss is a cause for concern. So basically, if you're going to be in caloric restriction, especially if it's going to be long-term, then you have a high risk of basically decreasing your bone mineral density, which is not good because as you get older, one of the number one killers is breaking your hip, going to the hospital, getting pneumonia, surgery, C. diff, and whatever else, and then dying in the hospital. So it's essentially a function of frailty. And so you don't want to be doing things that are going to decrease your bone mass down the line just so you can lose weight now and wind up running into issues. Now, the trials for the GLP-1 agonists are in these 1 to 2 year time frames, sometimes a little bit less, sometimes possibly a little bit more, but essentially they're not as long as some of the caloric restriction trials. And these drugs, the reason I'm bringing this up is people are talking about using these drugs perpetually to keep the weight off because people are regaining the weight so quickly when they stop. So then we have to start considering that there's risks associated with doing that and running this long-term caloric restriction, which includes nuking out your bone mass and increasing your risk for fractures and frailty as you get older. However, there is a solution here. And you're going to guess it correct. It's resistance training. So let's talk about that. So they say here another concern regarding body composition following caloric restriction interventions is the bone mass loss, which exercise is shown to prevent, at least in rodent models of male senile osteoporosis. Resistance training is known to be highly effective to increase bone mineral density after long-term interventions in humans. So basically, if you want to prevent the bone mass loss as well as the muscle mass loss when you're calorically restricting or using these drugs, which cause caloric restriction by nuking your appetite, then you're probably going to want to work out. You want to go in resistance train, which again, you could just resistance train and put it in an appropriate deficit and lose the weight without necessarily having to resort to these drugs to nuke your appetite. So this is kind of the whole perspective is like, what's the risk versus reward, and what are the other options we have on the table? What works better and what has least problems? Resistance training and an appropriate caloric deficit work better than these drugs with less side effects and less long-term risks. And that's kind of what I'm pointing out. And the weight loss of these drugs is just caloric restriction at the end of the day by nuking your appetite centers and slowing down your digestion. Plus, you now have these problems where you're not digesting your food as well, and you're nauseous and you're vomiting and you have diarrhea and you have constipation, which leads to a lot of people coming off. So again, high rate of coming off, lots of side effects, weight loss isn't as good, and possible problems, not that many problems, probably not that much digestive issues. Weight loss is pretty good. It's like, which do you want to choose? Which is more effective? It's the exercise caloric restriction route more than these drugs. Now, next thing I want to talk about that can actually improve lean body mass loss during caloric restriction is you need to eat enough protein. So what they say is preservation of lean body mass with caloric restriction can also be obtained by additional protein intake. Longland and colleagues have shown that caloric restriction plus resistance training with high protein consumption induces an increase in lean body mass and promotes larger fat loss if compared to caloric restriction with low protein consumption. The only study that has investigated the caloric restriction effects in combination with higher protein intake, 30% compared to 15% of the rest, found lower lean body mass loss than the others. So essentially, if you want to optimize your fat loss, if you want to dial in and maintain your lean body mass loss, you're going to need to eat enough protein. You're going to need to appropriately exercise, resistance train, lift weights, or do something along these lines, whether you are using GLP-1 agonists or not. And then on top of that, you might as well just get the rest of your diet dialed in when you're using the GLP-1 agonist, because another problem that you run into with caloric restriction, and this is talked about, as I mentioned in the bone mineral density study, is that people are running into nutrient deficiencies, vitamin A, vitamin D, calcium, magnesium, iron, when they're drastically decreasing their food intake. So that would mean that if you're going to calorically restrict appropriately, you need to make sure your diet is dialed in effectively. So if you're going to use a GLP-1 agonist that drives caloric restriction, then you need to dial your diet in appropriately as well to avoid some of these problems. You need to eat enough protein and you need to eat enough vitamins and minerals so that you can actually maintain your function over the long term. And so essentially, whether you're on these drugs or not, you're still going to have to get your diet right. You're going to have to get your exercise right. So why don't you just don't go this direction anyway? Because if you don't get this right, the probability at this point in time is that you're going to go on the drugs, get side effects, and at the 1 year mark, half of people are going to drop off. And at the 2 year mark, 3/4 of people are going to drop off. And so we don't even know the 3 year mark yet. It's like at the 3 year mark, what is it, 90% of people are off these drugs? So this combination of effects, it just is more impetus to go in the other direction. It's to actually go in the exercise direction and the caloric restriction through exercise direction. And again, I want to remind you here is that the using exercise with liraglutide was superior to just using liraglutide alone in maintaining fat mass loss. Now, there's a couple other things that I want to point out here with these GLP-1 agonists. So there's some not specifically discussed effects that I found in the research that are possibly problematic. And one of them is that GLP-1 agonists seem to upregulate glucocorticoid signaling. So what does this mean? The quote here, they say, it was demonstrated that GLP-1 brain administration elevated the circulating concentrations of ACTH, adrenocorticotropic hormone. This is the hormone that signals the production of cortisol from the adrenal gland. And also corticosterone, and also enhanced anxiety and behavioral measurements. So these GLP-1 is increasing the stress systems, the hypothalamic pituitary adrenal axis, and increasing anxiety, and also increasing cortisol levels, corticosteroid levels. They say the stimulatory effects of GLP-1 on the HPA axis were not limited to rodents. Increased cortisol levels were observed in both healthy humans and type 1 diabetic patients to whom GLP-1 had been administered peripherally. Recent findings from studies on humans and animals demonstrate that GLP-1 receptor agonists can also modulate the stress response via the hypothalamic pituitary axis activation, but data obtained so far are ambiguous. These data showed that subchronic 7 to 14 day administration of Exendin-4 or liraglutide administration in rodents resulted in hyperactivation of the hypothalamic pituitary adrenal axis, disruption of glucocorticoid circadian secretion, hypertrophy of the adrenal gland, and dysregulation of the pituitary adrenal stress response. So these drugs are also seem to be increasing the hypothalamic pituitary axis, which is not good when we consider the long-term effects of cortisol, which I've discussed in many times on the Energy Balance podcast, on my own YouTube channels, etc. And so essentially, and this seems that it's unrelated to the weight loss and the caloric restriction because this is occurring within 7 to 14 days. So it's unlikely that the deficit is that extreme at that point. I could be wrong, that maybe they're just going into a caloric deficit pretty quickly by having the appetite nuked out and having digestive problems, but it seems like this is happening relatively quickly. This is not like something that's just happening down the line and is a function of people not eating enough over the long term. So another thing that I want to talk about here is when you are setting up an appropriate caloric deficit, you need to be careful because caloric restriction and caloric deficits can cause issues with your hormonal profile. So I'm going to talk about some of the effects on the hormonal profile from the caloric restriction studies. So the effect on thyroid. For thyroid hormones, they say here, the cronies, which is a study on caloric restriction, have significantly lower T3 levels, but not T4 or TSH concentrations compared to age, sex, and weight match controls. The 8 individuals confined in Biosphere 2, this was another study, lost a considerable amount of weight during the first 6 months of their 2-year experiment due to a shortage of food and also had decreases in thyroid hormones. So they say, oh, it's no big deal, just T4 and TSH concentrations are okay, but T3 is actually what gets lowered. Just T3 gets lowered. Well, this is problematic because T3 is the main hormone that has the effect. T4 and TSH don't have a specific effect at the target cells in terms of thyroid hormone function. It's T3. So basically seeing the lowering of T3, and I would assume an increase or reverse T3, which means that you have less thyroid activity even if TSH and T4 are fine. So that's not necessarily an argument in favor of this. This is actually saying that caloric restriction is negative to thyroid function. Now the next one is cortisol. They say in this study, specifically this study found that moderating one's diet increased perceived psychological stress and restricting one's caloric intake increased total daily cortisol. These findings lend support to the idea that stress may be a mechanism of diet failure. They continue, restricting, on the other hand, increased total cortisol output among the participants consistent with previous research. This finding may seem unexpected, as restricting caloric intake can trigger mechanisms to reduce energy expenditure, including reduced corticotrophin releasing hormone output, which in turn may reduce cortisol downstream. However, restricting caloric intake may be a biological stressor because one of the main functions of cortisol is to increase the availability of energy in the body. The stress resulting from restricting one's caloric intake to a mere 1,200 kilocalories or 1,200 calories, therefore may have reduced the absolute amount of energy available to the body, therefore leading to increased cortisol output to release energy stores. So basically, when you don't eat enough, your body upregulates cortisol to release fat and amino acids from your tissues so that you have fuel sources. And so basically what we're seeing is caloric restriction causes stress. We know this. We've talked about this ad nauseum, but this is something to keep in mind, especially because there's reports of people developing issues when they undergo caloric restriction and hormonal issues, including thyroid, including sex steroids, which we'll talk about right now, and then also issues with their bone mineral density. So we want to keep these things in mind. Next one is male hormones. So what happens to your testosterone? So when you're in caloric restriction, these researchers say significant decreases in total testosterone concentration were reported in 2 of 3 studies in which the effects of caloric restriction were examined with normal weight, healthy men compared with the control groups. In all 4 studies that examined the effects of caloric restriction on sex hormone binding globulin concentrations, the intervention significantly increased sex hormone binding globulin concentrations compared with that of the control groups, irrespective of body composition. So caloric restriction lowers testosterone and increases sex hormone binding globulin, which essentially means you have less free testosterone floating around because you have a lower total amount and a higher sex hormone binding globulin that binds that testosterone up, which means you have less testosterone effect, which is not good. This is lowering male hormonal function over the long term. So we're seeing lower thyroid, increased cortisol, lower male hormones like testosterone. Now let's get to women. In women, when they undergo caloric restriction, it basically nukes their hormonal situation, the whole hypothalamic pituitary ovarian axis. So they say in women, caloric restriction enables the development of hypothalamic amenorrhea. So basically a lack of the period, a lack of the menstrual cycle. They say the direct pathology is the impairment of the hypothalamic pituitary ovarian axis. This is the axis from the hypothalamus, your pituitary gland, on the ovaries. The reduced gonadotropin-releasing hormone secretion attenuates the gonadotropin secretion. Therefore, ovarian follicle development and estradiol synthesis are inhibited. So basically, the brain stops producing the hormones that tells the ovary to produce estradiol and also to develop the follicles for ovulation and for pregnancy and whatnot. Then they say the insufficient estradiol concentration cannot trigger the pre-ovulatory gonadotropin surges, culminating in anovulation and amenorrhea. So basically, ovulation stops and the period stops. And they also say the reduced plasma leptin and increased plasma ghrelin, which represent the low energy status, compromise the function of the hypothalamus pituitary ovarian axis and thus result in amenorrhea. So basically, if you undergo caloric restriction, you can lower your thyroid function, increase your cortisol, lower your testosterone if you're a man, or nuke your ovarian function if you're a woman. And so when you're using these drugs, which again are working through caloric restriction, you need to understand the risks and ramifications of undergoing caloric restriction, especially if you're just hopping on liraglutide or semaglutide and you're not exercising and you're not making sure your protein intake is dialed in and you're not making sure that your micronutrient intake is dialed in. And also, we won't even get into talking about whether this is a low carb or low fat diet because I'll go on a huge tangent. But essentially, if you need to make sure your carbs and fat intake are dialed in effectively. And this is also not to mention that you will likely develop digestive issues when using these drugs because they drastically impair digestive function by slowing down the rate of foods, the rate of digestion in the digestive tract, and also decreasing stomach acid production. So, and also increasing nausea and vomiting through those mechanisms. So you have a lot of downsides with these drugs. You're going to have to exercise and fix the diet and do all of these things anyway if you're on these drugs, if you want a long-term beneficial effect. So my personal thought process here, my takeaways from this is essentially diet and exercise still reign supreme. These drugs, there's no free lunch with these drugs. They are not going to basically make you lose massive amounts of weight and be able to maintain it once you get off these drugs. In most circumstances, the vast majority of people, at least from the research that we're seeing now, are not able to do that. And if you want to minimize the loss of lean body mass from these drugs, then you need to eat well and exercise anyway. So just eat well and exercise and avoid these drugs in terms of nuking out your digestive function, etc. Now, the only thing I'll say here, and an argument can be made for this, and I've seen arguments for this, essentially, if somebody has a hard time sticking to diet and exercise and wants to see results, then they could say, I'll start these drugs for a period of time, get all these other things right, and then I'll come off. You could possibly do that if it's really that hard for you to dial in the diet and exercise and these different components. And you can make an argument for that maybe it helps you get over the hump and then you lose the weight because there's problems with having this excess weight. I can see an argument for that. But at the end of the day, I think the primary and most important piece to focus on is that getting the diet right and exercising effectively are going to be the best strategies possible to lose weight and improve your health, regardless of these new and hyped up drug regimens. Now, if you are, the biggest problem that people run into is like, how do I actually do these things? And so if you're wondering how you can set up your diet or how you can exercise or anything along these lines, that's what this channel is about, to provide this information. But for the dietary piece specifically, you can check out the nutrition blueprint that I have on my website, mikefave.com, where it teaches you how to set up your diet appropriately, dial in your protein intake, and then manage your fat and carbohydrate intake so that you can actually, if you're going to use these drugs or you wanted to lose weight, set these things up appropriately before you hop on board. So that's what I have for this video, guys. If you like this type of content, please subscribe, please like, and then if you want to give any ideas for future episodes, please comment down below.